next session. The person who takes, next chapter, the person who takes medicine must recover twice, once from the disease and once from the medicine. The famous quote from the father of medicine, William Osler. We microbiologists, we go according to our father, Louis Pasteur. So this is a physician. William Osler said, a person who takes medicine must recover twice, once from a disease and once from the medicine. Antibiotics, when we give, always one complication every ID physician or every physician will have in their mind is C. difficile, Clostridium difficile. Oh, sorry, it is Clostridioides difficile. Right, see, when I learned it was Clostridium difficile, now it is Clostridioides difficile. Still, this Clostridium is coming in my mind. The same way, all are being physicians been trained to give antibiotics. When we say about phages, it's very difficult. So it's our duty, microbiologist duty, whenever we dispense a report, a pan drug resistant, definitely you will be getting a call in corporate setup or anywhere you get a call from the physicians. Doctor, you have given a report as pan drug resistant. None of the antibiotics are going to work. What is the option left over? Just educate them and advocate them about phages. Microbiologist, the role of microbiologist and the glory of microbiologists went up during the pandemic. People died. Pathetic. It was so pathetic to see. My ID physician who has joined as a moderator said to me, the most pathetic death for a man is that lack of oxygen. He taught me during my fellowship period at Madras Medical Mission. He was one of my mentors. Right. So that was very pathetic that people died, lack of oxygen. I was a COVID nodal officer in Venkateswara Medical College. I saw people dying there. Right. So I used to see Boston, given an opportunity, I did something, but we were not warned. Now, already the AMR pandemic is there because COVID killed 30 lakh people in a year. Totally 60 lakh people all around the globe we lost in 2 years. In 2024 alone, 50 lakh people have died. That's the reason why this is called a silent pandemic, because no media covers and no public knows about that. Now, another 25 years are there. 2050, full swing is going to happen. Full swing. What can we do? What is the pandemic preparedness? As a microbiologist, as a physician, as a doctor, what can we do? This CME will help you out. More thankful to the IIM Pondicherry chapter, Best of ID, and the Society of Bacteriophage Research in Therapy for helping us out, for coming out the CME, right? In a very planned manner. Whenever you talk about Clostridium difficile infection, 4 things must come to your mind. 4 drugs: metronidazole, vancomycin, fidaxomicin, and fecal microbiota transplant. I don't see any ID physician prescribing metronidazole. Usually they go for vancomycin. So vancomycin has been given. The article comes in IDSA saying that reduced vancomycin susceptibility. So vancomycin is losing its shape. Next is fidaxomicin. Availability in LMIC? Question mark. We are talking about recurrent Clostridium difficile infection. For recurrent Clostridium difficile infection, RCT is being conducted on fecal microbiota transplant. Again, affordability, availability in LMIC, the question mark. So, verdict of this chapter would be, we need a surgical strike. ID always teaches, the first thing in ID is syndromic approach. Patient says something, first pin down which syndrome is, which system is getting involved, come for a syndromic approach. This is what the ID physicians teach me. This is what I was taught. Syndromic approach. Any antibiotic you give, it is going to touch your microbiome. Without touching a microbiome, can you just say any one antibiotic which is not going to touch your microbiome? No. So any infection is there, we need a surgical strike. Surgical strike on the offending pathogen is needed. So is this the need of the hour? Any antibiotic you give which is going to affect your microbiome. So we don't need that one. Phage will not touch your microbiome. As a microbiologist, we have been, as a student, first MBBS student, then microbiologist, PhD research scholars, we have been taught and we have been teaching only about the good bacteria in the gut. What I say today that you have bacteriophage in your gut also. Those are called as good viruses, bacteriophages. That community is called as phagiome, right? So phagiome is there. Once the good bacteria dies, your phagiome is disturbed and you'll end up in all sorts of problems. So whenever I talk about microbiome, lot of research is going on. If you closely follow IDSA articles, one of the modality to mitigate AMR is to replenish the lost microbiota. That is also one of the modality. So microbiome is very important. whenever we talk about microbiome, we have been taught there is something in the gut. You have a microbiome in the brain also. Still research we should do. I think the entire body is full of microbiomes, right? Research, when that's what we say, when you go deep into research, you come to know about your ignorance. So in this chapter, we'll talk about microbiome. Once we touch the microbiome, what happens? Antibiotics are being given, what happens? The patient lands patient lands up in obesity, diabetes, allergy, autoimmune disorders, neurodevelopmental disorders in children, and certain cancers. Very worrisome, right? Very worrisome, these cancers. So this picture is taken from 2014, right? The years are very important. 2014, there's a report from WHO stating that AMR in 2050 is going to take 10 million. It is in 2014. Now it convert to Indian, what we say is 1 crore. 1 crore people are going to die in 2050. Now articles are surfacing as 4 crore. We don't know what is really going to happen in 2050. And cancers was predicted to be 8.2 million in 2014. So this is in 2024, American Association of Cancer Research says in 2050 it is going to be 18.5 million. In 2014 it was 8.2 million, and 2050 it is 18.5 million. I don't know what is going to really happen in 2050 because of cancer and AMR. So this cancer and AMR, I believe it is going to wipe off half of the population like what Thanos did with a snap with the 6 infinity stones. I believe with 6 is not needed, just 2 is needed. 2 is enough. AMR and cancer, these 2 infinity stones are enough to wipe off half of the human population. So one calculation says that every minute 40 people are diagnosed with cancer, right? And cancer turns the lives upside down. People who have worked microbiologists in cancer centers, you see people, they're very devastating. Once the patient you have been labeled as cancer, the life turns upside down for them, right? Particularly in LMIC, poor people, right? Affordable with insurance, okay, they can run the show. And AMR makes the battle even harder. We have been talking about COVID pandemic, AMR pandemic. One more silent pandemic. What we say is colorectal cancer is really a pandemic. The article says colorectal cancer is a pandemic. So many reasons we can put forth. One reason is antibiotic abuse, not use. We are not against antibiotics. Today I'm 40, I'm standing in front of you. It's because I have taken antibiotic for my infection, I am surviving. Right. So judicious use, that's what we say, judicious use. At times, we need a fast therapy. That's a good Samaritan. So the verdict of this session would be we need an alternate arsenal to fight infection in cancer patients. Next chapter would be on emerging nosocomial pathogens. As a microbiologist, we see samples from immunocompromised people grow different types of organisms. They grow different types of organisms. All new terminologies, right? New terminologies. We read that organism and we see whether this organism really will really cause some infection. Then we come across some case reports. Yeah, that too causes. Whenever this emerging nosocomial pathogens come in VITEC reports, 2 things must come to your mind: biofilm formation and intrinsic drug resistance. These bugs are intrinsic drug resistant. So once they are intrinsic drug resistant, we are left out only with very handful of antibiotics. Very handful, only handful of antibiotics. How long this handful of antibiotics are going to work? Bacteremia, we divide into complicated bacteremia, uncomplicated bacteremia. Uncomplicated bacteremia, IDSA guidelines is 7 to 14 days of antibiotics, and complicated bacteremia, 6 weeks of antibiotics. These nosocomial pathogens will end up in causing bacteremias, usually complicated. We need 6 weeks. And we saw a case of cefiderocol, ceftazidime, avibactam working for 10 days. And this Stenotrophomonas maltophilia, I will not forget this organism. It is because this organism I encountered during my fellowship in a patient, which made me to take interest in phage. And today I am a phage enthusiast today. I'm standing in front of you. And biofilm formation. Biofilm formation. These organisms are more prone to form biofilms, and majority of antibiotics find very difficult to penetrate to the biofilm. So this is the CLSA guidelines. We saw the enterobacterial CLSA guidelines, Pseudomonas. We had a lot of antibiotics, right? Tier 1, Tier 2, Tier 3, Tier 4. All the 4 tiers, we had some at least named 2 or 3. But here, if you see for stereotrophomonas haemophilia, 35th edition of CLSA guidelines, we have only 4 antibiotics. How long this 4 going to work if a patient lands up in stereotrophomonas haemophilia bacteremia? Left to you to decide. In these cases, we need Phage as a good Samaritan. Do we have Phages for stereotrophomonas? Yes, we do have Phages. Dr. Shobna Sukumar has done a work. She is also joining our session, our CME today. She is from SRM Katangaluthu, an Indian who has done a work on Phage. So Phages, you ask where do you where the first Phages was discovered, where this Phages came in. It's all from India, all from Mother Ganges, right? And today we question how far Phage is going to be effective. Left you to decide. It's all from India, and India is majority of the death from AMR is going to be from India. We saw Phages from India, and it's our duty to make Phage as a therapeutic option. It's all we have to request ICMR through case reports to clinical trials to make Phage therapy a promising therapeutic option in India. The verdict would be of this session would be emerging nosocomial pathogens need plan B. The plan B would be Phage therapy.